because not all patients respond to combination of chemotherapy and immunotherapy. The most common regimen that we use is something called R-CHOP, or R for rituximab, and CHOP is the combination of other chemotherapy agents that we use for patients. That regimen is typically effective in a lot of patients, but some of them may not respond well to the treatment, or they progress quickly right after that. So before they even consider the next step, which could be a stem cell transplant, for example, then clinical trials become to mind. So let's talk about lymphoma. So lymphoma is a disease that is a form of cancer that happens typically in the lymph nodes. That's why lymphoma name comes to fruition, right? So, and they're affecting the cells that we call lymphocytes. So lymphocytes are, defense cells in our body that they are typically located in lymph nodes throughout, and their main function is to actually fight infections or cancers when they occur. So it's not uncommon that if someone has, for example, an infection, you see a lump. Maybe when the tonsils get enlarged is because those lymphocytes are growing and fighting, whatever infection is happening at that single time. But when one lymphocyte becomes abnormal and it starts to grow on its own in a malignant way, we call that lymphoma. There's two kinds of lymphomas, at least in big, level classification. One is what we call Hodgkin's lymphoma, which is a specific form of lymphoma that happens in young patients or very old patients, and is characterized by specific features on the cells of the lymphoma, how they look under the microscope. That's a less common one. The most common one is what we call non-Hodgkin's lymphoma, and that comprises several subtypes of lymphomas, all differentiated based on the type of B cell or T cell affected. Many of those are B cell lymphomas, and these lymphomas themselves have different features depending on the level of aggressiveness or certain mutations inside of those lymphocytes. It's not uncommon that the lymphoma cancer that some patient may have is completely different from the neighbor that's getting chemo on the same infusion place. Every single cancer patient is unique, and in lymphoma is even more true because every single lymphoma has different features, and all of them have different evolutions over time, what we call natural histories. So certain lymphomas are more what we call indolent. So for example, the case of follicular lymphoma, or the cases of CLL or chronic lymphocytic leukemias, those are lymphomas that are B cell type, but they are more indolent. That means that it's going to take several years for the patient to even require treatment. And when they require treatment, they may not necessarily require multi-agent chemotherapy drugs to treat the cancer itself. Sometimes you can treat it with certain pills, for example, that target the growth of the B cell at that time. And those are called BTK inhibitors. There's a number of them: ibrutinib, xaluritinib, many of those that finish in IB. Those are inhibitory molecules that we use for patients with indolent lymphomas mostly. When the lymphoma becomes aggressive, sometimes one of those follicular lymphomas over time starts to become aggressive. It changes the genomic information inside of them. They become what we call aggressive lymphomas. And the most common example of that is something called diffuse large B-cell lymphoma, or DLBCL. The diffuse large B-cell lymphoma is called like that because they're like large cells, they're diffuse, and they're very aggressive. And they start to appear not only in one side of the body, but they go across multiple lymph nodes. So the classification of lymphoma, beyond the way it looks under the microscope or looking at genomics, is also based on staging. Staging is the extension of the cancer compared where it came from or where it started from the beginning. So let's say it started on a lymph node on the right axilla. But if we see lymph nodes that are affected by lymphoma on the other side of the body, like for example the other axilla, then we start calling it like a stage 2. But if it goes below the diaphragm, which is the muscle that divides the chest cavity from the abdomen, and then we call that a stage 3 or a stage 4, depending on the amount of lymph nodes involved. We also have a classification that is based on symptoms. So if you have no symptoms from the lymphoma, for example, you don't have any weight loss or fevers or night sweats, like drenching night sweats, then you call that, for example, a stage 4A, because it's in 4 quadrants of the body, above and below the diaphragm, but also you have no symptoms. But if you happen to have any of those symptoms of unintended weight loss over the last 6 months, night sweats or fever, then you have B symptoms, and then we call those patients having a stage 4B. That is a significant difference because every patient, depending on the stage, beyond the aggressiveness of the lymphoma itself, can have different prognosis. So of course, the more advanced cancers, they have the more difficulties in managing them. When that happens, we always encourage clinical trials. Why? Because not all patients respond to combination of chemotherapy and immunotherapy. The most common regimen that we use is something called R-CHOP, or R for rituximab, and CHOP is the combination of other chemotherapy agents that we use for patients. That regimen is typically effective in a lot of patients, but some of them may not respond well to the treatment, or they progress quickly right after that. So before they even consider the next step, which could be a stem cell transplant, for example, then clinical trials become to mind. So all patients with lymphoma, no matter where they are in the journey, should always be encouraged to look ahead of the options, because you never know when the time is right for you to choose the best next step for your cancer journey. All the clinical trials that have been done over the last few years have led to novel developments that now are really becoming a standard of care for patients. So one example of a potential treatment option for lymphoma patients who have progressed or have cancer progress after chemotherapy is what we call CAR T-cell treatments. So CAR T stands for chimeric antigen receptor T therapy. And those are your own cells that have been modified to recognize a specific biomarker on the lymphoma. And they become like a SWAT team. So basically, you train your own cells to recognize the enemy, and then you grow the army, and then you infuse them again into your own body. And now they have the ID and they have the address or where to find the cancer and eradicate it from the body. Clinical trials have been the opportunity for those patients to enroll on CAR T-cell treatments before they were approved, and they have paved the way for many other patients now having that option in front of them, which is changing lives. So I encourage every single patient, no matter where they are in the cancer journey, to always consider clinical trials for the next steps, just to be proactive, just to have those options in front of you, because that's what I would like for myself and for my family, right? You want to have all the information that you need in real time and use technology to make sure that you actually have this information available in real time. So we have created an app in a website for patients at Massive Bio, where any patient with any kind of cancer, especially, for example, lymphoma, they can search for options even from diagnosis and start lining up the potential treatments across the cancer journey. Whether you just started treatment or you are post-CAR T-cell treatment and the cancer is progressing for whatever reason, we are here to help you, and we want to help as many patients as possible across the world with this technology in real time. So I welcome everyone to give your comments, check on our website, check our tool or apps, and we're here for you. Thank you so much.